No mai, haere mai. Welcome everybody to our webinar this evening. Thank you so much for joining us. Tonight's webinar is brought to you by Fertility New Zealand. We're a charity that has supported Kiwis in their journey to building whānau for 30 years now. We offer information, support and advocacy, and for more information on what we do, please visit our website. We've got support groups that run around the country. They're meeting virtually at the moment, and a range of resources as well as a helpline. So we'd be really pleased to support you on your journey. Tonight's webinar, as you know, is all about IVF. And it's my absolute privilege to welcome two wonderful speakers we have here tonight. Just a word about the format. There will first be two presentations that will be followed by a Q&A. So please hold your questions until the end and then type them into the box and they will be answered by our two speakers. So I believe they'll be doing a presentation each, and the second presentation will be by Dr. Andrew Murray, who is Medical Director of Fertility Associates in Wellington. And the first presentation will be by Dr. Mary Birdsall, who is Group Medical Director for Fertility Associates and based in Auckland. So without further ado, it's my absolute privilege to pass over to Dr. Mary Birdsall, who will speak to you about IVF. Thanks.
Thanks, Nicola. Thank you so much for asking me to speak. So what I'm going to do is just really set the scene, just to talk a little bit about where does IVF sit and why might it be a great choice for you. So the first question to say is, what ingredients do you actually need to make a baby? And what you need to make a baby is, first of all, you need a great egg, and then you need the sperm to get to the egg, and then you need to have a normal uterus. And in terms of if you're conceiving naturally or with a low-tech fertility treatment, the sperm need to be able to swim from inside the uterus all the way along the tube and meet the egg. So sometimes we do IVF because you've got something really wrong with you and it's a really big thing, and IVF is really the only option. So the sort of things around that would be really severe sperm issues. So the sperm are just not going to get to the eggs if they have to make that big journey by themselves. Or if a woman has blocked tubes, and where there is blocked tubes, there's no other alternate to becoming pregnant aside from IVF. Or where a woman has really, really bad endometriosis, where the endometriosis produces some substances that really affect the sperm and the egg getting together normally, and often the severe endometriosis causes incredible distortion to her pelvic anatomy. And then there are other people who've been trying for a super long time and it's just not working. And for those people, sometimes if you've been trying for 5 years or more, and even if a reason hasn't been found, statistically, you're down to about a 1% chance each month of doing it yourselves. So they're people for whom IVF is really an obvious option. There are other people, however, for whom they might just have a whole lot of little issues that exponentially make up being a far bigger issue. And the sort of things that we sometimes see people have is, say, some mild endometriosis, and someone who is partnered up with someone whose sperm isn't terrible, but it is just has some days where it's not so great. Or women who, say, have a lowered AMH, so they don't have as much time to conceive. Or people, and certainly in pre-COVID times, who just may not be together at the right time each month because they did that thing we used to call travel. So, often fertility is a whole lot of little issues that add up to where IVF can be a really good option. So when we conceive naturally or with the low-tech treatments, we actually never know if this actually happens. So this is a highly magnified view of a sperm that's literally coated, a big picture of an egg with a whole lot of sperm that are literally coating that egg. And so why IVF is way better than our low tech treatments is in IVF we actually know this happens because we get a whole bunch of eggs and we put the sperm together in our laboratory. The other reason why IVF is a whole lot better than any other treatment is because generally we give a woman drugs when she does IVF, so we get a batch of eggs, and the average number of eggs we get is 9. And that differs across a normal menstrual cycle where a woman only ovulates 1 egg. So we have a whole lot of eggs for the sperm to aim at. And then our clever embryologists have a variety of technologies where they can choose the best embryo. So an embryo is a fertilized egg, and the embryologists watch carefully throughout the time the embryos are in our lab, and they grade the embryos, and therefore they can choose an embryo that's much more likely to be a baby. Another huge advantage of IVF is that often there are some spare embryos, and they can go in our freezer and work just as well as a fresh embryo. And those frozen embryos provide you with another chance for having a baby, and therefore and they don't get any older as they sit in our freezer. So if, say, you're a woman at 38 and you've been trying for a year and nothing's happened, and maybe you have a modest AMH, then doing an IVF cycle where you're going to have the best chance of having a baby, and also maybe having some spare embryos for future children, is actually a really, really worthwhile plan. So IVF is our single best fertility treatment in terms of the chances of having a baby. And what it really does is just give you the shortest time to getting a baby, because we all know how tough it is. And I think the trying is really a really difficult part of the journey. So going more directly to the treatment that's most likely to get you there, for many people is a great option. Um, the other thing about IVF in terms of how much more successful is it than just having sex, the answer is it's a whole lot more successful. And this is what this graph shows. So this is age of a woman along this axis. And this says that, say, if you're a 30-year-old woman and you have perfect fertility and you're with a guy who's got amazing sperm, and you've been trying for less than a year and you're having sex at exactly the right time, then your chances of getting a baby that month are only about 22%. But if you do an IVF cycle, your chances are 50%, and you might get some spare embryos for more opportunities. So IVF really is a great option, worthwhile considering, sometimes a little bit earlier than you would think in your journey. I'm now going to hand over to my lovely colleague, Andrew Murray, who is our medical director in Wellington. And Andrew's going to talk a little bit more about what goes on in an IVF cycle. So thanks, Andrew.
Thanks, Mary. It's really a privilege to join you all tonight. What I'm going to do is share a screen with you here with a little presentation all about what actually happens in a typical IVF cycle. And what I'm hoping to do with this is to perhaps demystify the process of IVF, because I think many patients that I've met over the years have this concept that IVF is in some way this really scary, long-winded process that you only undertake as a last-ditch effort. I can't agree more with Mary's concepts that she's putting across here, that shortening that time to the baby is certainly well worth considering for many of our patients, and that concept that the combination of many little things but working together is often overcome by looking at IVF as an option. So in terms of what actually happens in a typical IVF cycle, It all starts with a woman's period. So when our patients have had IVF presented to them as their best option, the first thing they'll do is call us on day one of their cycle. Now, we define day one as the first morning of bleeding. So I know there's sometimes it can not be completely clear whether the period's starting or not. If it's a bit of spotting in the afternoon, we wouldn't define that as day one. The next first morning of proper bleeding is what we would define as day one. And for most IVF cycles, the first medication we use is called follicle stimulating hormone. So this is exactly the same hormone that your own body produces to recruit an egg, except what we're doing is providing a higher dose of this so that instead of just one egg being recruited, there's actually up to, in many cases, more than 9, but on average we get about 9 eggs recruited, some women more, some less. But the idea is that we recruit more eggs to work with to therefore improve the chances of getting a good egg. I often liken this to athletes lining up at the start of a running race, and women often ask me, well, hang on, if you're recruiting more eggs, does that mean I'm going to lose more eggs each month? Well, in fact, each month when you ovulate one egg, there's actually about 9 to 12 other eggs recruited in the race. And so a good way to think about this is that follicle stimulating hormone is performance enhancing drugs for those other eggs that would normally get to die off. We're actually enhancing them so that they can get all the way to the point of actually being usable. Another counterintuitive thing about IVF is that we actually don't want you to ovulate, because if you ovulate and release your eggs, it means that we then can't collect them because they've been released into the abdominal cavity, and we have no way of picking them up. So there is a second drug, we call it an antagonist. It's not an angry drug, it's just helpful at stopping you from ovulating. And so this commences 6 days into treatment. The first insight into how you're responding is typically on the 8th day. And so what we're looking at here is an ultrasound of an ovary that's going through IVF. And as you can see here, we're trying to recruit somewhere between 6 and 12 follicles. Some women might get more, some will have fewer, depending on what their egg reserves are. But if you just have a closer look here, you can see these dark circles, they're what we call follicles, and each one of those potentially has an egg in it. Now, for most women, by about the 9th to 12th day, these follicles are large enough that we can expect the eggs inside to be ready to be fertilized, or what we call mature. And so it's at this point that we then arrange the egg retrieval. Now, for those of you watching around the country, all of the things that I've described so far can usually all be performed in your own local towns or very close to your local townships. You don't have to be in one of the main centres to have blood tests or ultrasound scans. In my own practice, I have a lot of patients from Hawke's Bay, from up around Gisborne, the Manawatu, Wanganui, and I know Mary has patients from as far afield as North Auckland and so forth. So we can manage a lot of this remotely up until this point. The egg retrieval, this happens 36 hours after we've established the eggs are ready, and the way we go about retrieving these eggs is it involves having usually an intravenous line where we give you some pain relief and some sedation, so you're not knocked out like a full operation. In fact, most women chat to us during this process, but you certainly feel very relaxed. The pain relief is a very powerful pain relief, and it works really well. But the other really great development, in my view, in the last few years is the use of local anesthetic as well as those medications. If we look here, you can see this area here I'm highlighting just at the top of the ultrasound probe. We numb that area so that we can then safely put a needle into the ovary to take the eggs out. And while we're doing that, we're actually using the ultrasound imaging to see exactly where the needle goes. And so we then systematically just remove each egg from each follicle, Typically, this would take about 6 to 8 minutes. It's a very quick procedure. That same day, obviously we need some sperm to put with the egg, and just linking back to Mary's point before, this is the only treatment we know for sure where the egg and the sperm get to meet each other. You know, everything else that it's not IVF or natural conception, we hope the sperm finds the egg, but we don't know it does. Whereas one of the main advantages with this approach is that we know for sure they're going to get together. In terms of insemination, the two main ways we introduce the eggs and sperm to each other is either through what we call just standard IVF, where we put a bunch of sperm with the eggs and leave them to fight it out between themselves, and hopefully one of them wins the race. But in couples where there's either been a failure of this process in the past, or indeed if the chap has a lower sperm count, we'll actually pick the best sperm and put that directly into the egg. From there, what we're looking for is embryo development. And so over the next 5 days, and this is what would normally be happening in the fallopian tube and the uterus, the fertilized eggs start dividing as they become embryos. So they go from this single cell to 2, 4, 8 cells, all the way through to this stage called a blastocyst. And so our embryology team, in the past, they would do checks on the embryos at specific points in time. We have newer ways of keeping an eye on them, and I'm going to talk a bit more about that in a moment. A really important point to understand is that we do have an attrition rate. And what I mean by that is, for example, if you had 10 follicles, it would be pretty unusual to end up with 10 embryos. From 10 follicles, we might get 8 eggs. So not every follicle will give us an egg. And from the 8 eggs that we introduce to the sperm, well, we might have 6 that actually fertilize. And so by the time we go through the various stages to pick the best embryo, there may only be 2 or 3 from that initial 10 follicles. Another key advantage of IVF over any of the other treatments is it does provide us with an opportunity to pick who's the best embryo. And an area that I'm really excited about that's developed over the past few years is the role of time-lapse imaging of embryos. So I'm just going to show you a short video clip, which will hopefully be streaming okay to you all. So in front of you here, you can see 3 embryos developing. And this clip, it's about 30 seconds long. I'm not going to run it all the way through at the moment, but you can, what's happening here is we've got a special incubator that's taking a photo every 10 minutes as these embryos are developing, and that's then put together as a time-lapse image. Now, apart from being a cool thing to watch, what is the actual purpose of this? Well, let's go back to the beginning, and I want you to focus on the left-hand embryo. So you can see it starts off as a single cell, and then it divides into 2. There's a few fragments around it, but then it's gone to 4, and now it's continuing to divide. And you can see if you look across all 3 of these embryos, at this point they look exactly the same. Well, let's rewind the tape. We go back to the beginning, and I want you to have a look at the far right embryo. See, it's 1 cell, and now it's gone to 3 cells, and then it carries on. Well, studies have shown that embryos that do that 1 to 3 cell trick, they have a much lower prospect of becoming an ongoing pregnancy. And this sort of thing is something we would never have seen before time-lapse existed. And so what our teams are now able to do is to look for similar events and annotate when they're happening into a software program, which then scores the embryos. It basically gives them a score out of 10, ranking the ones from most likely to least likely to provide an ongoing pregnancy. And so whilst this doesn't change what the embryo actually is, it comes back to that central point that we've been emphasizing, shortening that time to a baby, shortening the time that we can actually find the best embryo for you. So once that's been achieved, we then put the embryo back, which is typically 5 days after the egg retrieval. And so that side of things doesn't require any anesthetic for most women. There's a very fine little plastic tube that goes through the uterus into the womb, And you can see that we again use ultrasound, this time on the abdomen, and we can see exactly where the embryo is going. And if there are any other embryos of good quality, will they get frozen for future use? And again, Mary's point is a really good one. You know, if you're in your mid to late 30s or even your 40s, you know, locking in time those embryos at the age you are now means that when you potentially are older, looking at your second or third attempt at pregnancy, you've locked in time your younger age or your younger egg's age. And I know this is actually a phrase that Fertility NZ has talked about in the past, and that we need to think about your last pregnancy, not your first pregnancy. There is one situation where we actually wouldn't put any embryos back straight away. And this is where some women, despite us being really careful with drug dosing and monitoring, some women will still respond really briskly. And so if the ovaries really get over enthusiastic, let's say, and we have 20 or more eggs or a really high estrogen, there is a unique complication called ovarian hyperstimulation syndrome. So basically what happens is the ovaries have over-responded to the medication. They swell up quite a lot. And that's usually going to be a self-limiting thing, but the one thing that will make that worse is pregnancy. And so putting an embryo back to then result in pregnancy hormone is really not a good idea in that situation. So what we would do is we still go ahead, retrieve the eggs, create the embryos, but we then freeze everything, let it all calm down, and then we can put the embryo, one of the best embryos, back the very next cycle. And the really cool thing is the pregnancy rate is exactly the same. Assuming we didn't have to do that, the normal time to do the pregnancy test is 14 days after egg retrieval. And clinics have different ways of delivering that news. We know that the hardest part is actually that 2-week wait. And I absolutely empathise with anyone that's been through that side of things. So the whole process from start to finish, it's about 28 days all up. So that, in a nutshell, folks, is what happens in a typical IVF cycle. All right, coming back for questions. Hopefully, I'm hoping, Mary, that all came across okay, because while I was sharing that with everyone, it was just on my screen. So I had beautiful. My heart in my mouth. I wasn't getting any text from you, so that's good to know. So I think we're both happy to take any questions at this stage, and Nicola's going to let them through.
So the first question is, how much does time-lapse cost, and do we do it for everyone? And the answer is that yes, it is an extra cost, and it's $950 to have time-lapse for all of your embryos. But for some people, that's a cost saving because it allows you to choose the embryo that's more likely to be a baby first. So you might save in terms of how many frozen embryo transfers you might need to pay for.
All right, so the next question is, with low normal morphology, would IVF or ICSI be decided on the day of collection, or would this be decided before the cycle? That's a really good question. I think it would be fair to say that most of us, when we're planning treatment with our patients, we, where possible, try to make that decision in advance, because it's always better to go into treatment with those really critical decisions predetermined. And I think there's a couple of reasons for that. The first is there are often extra consent processes to agree to with that. It helps our lab to prepare adequately, because there's certainly a lot of extra work for the lab team. But if you're a private patient, then there is usually additional cost when ICSI is being performed as well. Now, there are some patients where it could be a line ball call. And so ultimately, our advice will always be based on what we think is going to give you the best chance of a baby ultimately. So if on the day the sperm doesn't prepare so well and our embryology team say, hey, you know, we're not so sure how well this will work, then we would err on the side of injecting the sperm into the eggs in that setting.
why don't I take the next question? It's about if we would ever not collect eggs on someone who was hyperstimulated, so they might have 30 plus. And the answer is that we've got much smarter in the IVF world now, thank goodness. And we have what we call our get out of jail free card, which is a different trigger injection that we use. That means that OHSS is virtually something that doesn't happen anymore. So therefore we can salvage those cycles where we used to just discontinue them altogether. And so we would use an alternate trigger, go ahead and collect the eggs and create the embryos and freeze the embryos. And that, as I said, that saves the cycle and really has reduced drastically the number of women we get into hospital with OHSS.
I literally can't remember the last time I did admit someone. I mean, I know I have over the years been involved in patients who have had to go to hospital with this condition, but which is a really good thing. The next question, which I should have addressed actually, was about what about the medication after follicle retrieval? That's a great question. So one of the things, before when I was saying you don't ovulate with IVF, ovulation still has a really useful purpose. You need some progesterone around to maintain the lining of the uterus in those early stages of pregnancy. So we provide that artificially, usually with vaginal progesterone. So that starts the day after egg retrieval, continues until your pregnancy test, and then often for the first few days, if your natural progesterone levels have maintained, we'll stop those pessaries. Otherwise, that it will continue up through most of the first trimester.
How much extra does it cost to freeze your eggs? Well, most people who come through an IVF cycle decide at the front that they're either freezing eggs or making embryos. So the cost of an egg freeze cycle is a package cost. So it's $9,500 the first time you do it. The second time it's $7,800, and the third time it's $6,800. There are occasional people who want to freeze some eggs alongside embryos, and there is no extra cost for that.
Someone's asked, is time-lapse option available with public funding? Unfortunately, no, it is not. It is seen as an add-on. You can certainly ask for time-lapse to be performed if your publicly funded IVF is at a clinic that has time-lapse available. It isn't something that's universally available across the country, but certainly in the clinics that Mary and I are involved with, it is. But it is, at this stage, a private-only option. So most of the DHBs have, in fact, all of them, as far as I'm aware, have indicated to us that if someone wants to opt to have that as part of their publicly funded treatment and they are willing to pay for it, then that's no skin off the DHB's nose. That you can opt to do that. Absolutely.
So I get the BMI question, are we BMI police? And the answer is we're not.
No.
And so, but there are these rules, and you need to be a certain BMI to be put on the waiting list, and that BMI is 32 for a woman. And in the Auckland region, there's also a BMI criteria for men as well. So the guys need to be less than 40. Look, we ask everyone what they weigh when they come in the clinic, but then if I have a patient and they are above the BMI threshold, and I say to them, look, can you work really hard to get down to this BMI of 32, and why don't you just drop me an email when you reach that BMI, then I'll just fill out the paperwork at that point. So I'm not the weight police. I'm going to absolutely trust you. So yeah, that's how it works.
Yeah, I was just going to say it's a real trust system, isn't it, Mary? And we're not here to be the police. So, I mean, the other thing about BMI is there are recommendations around that based on the fact that it will help improve your chances of success and reduce your chances of having problems in pregnancy later on. So we're not just about getting you pregnant. We want you to have a as low a risk pregnancy as possible. But we're also realistic. We know that for many women, they're not going to get their BMI all the way down into the mid-20s or something like that. We want to work with you as best we can. There's a question about a couple under 35, but if the partner's sperm count is less than a million, you definitely need to see a fertility specialist. There is really no other option that's going to get you pregnant other than IVF with ICSI, where we take the sperm and inject into the egg. So if you haven't seen a fertility specialist already, absolutely should come and see one, and a couple in that situation would almost certainly be eligible for public funding as well. So that's someone that needs our help, so come and see us.
Next question is about alert level 3, which we hope is going to be over in a minute, but we'll wait and see.
I need a haircut.
So is your partner allowed to do his contribution at the clinic? The answer is yes, but we'd prefer not to, or more realistically, our embryologist would prefer you wouldn't, because after he does his contribution in the clinic under level 3, they need to go and wipe everything down. So that, but just so we're just so hygiene focused at the moment. So if you can do it at home and you don't live too far away, that would be great, but otherwise you absolutely can do it in the clinic. And then, can your partner be at egg collection? Look, currently I'm really sorry you can't. And that's just about keeping the social distancing, reducing the number of people in the clinic. And so we really hope that that's over in a minute.
Yeah. I know that's been a really tough thing for a lot of our patients. I've had a couple of emails from my own patients today around this exact issue, really upset about it. But, as a country, we've been doing what we can collectively. And like Mary says, it's about reducing the number of people in the clinic. So if, for example, there was an extra person in the clinic who was COVID positive, it just increases that sort of risk of exposure to other people. Hopefully by this time next week, this will change. Yeah, please. Right, someone here, I don't think we're not supposed to say people's names. Well, who knows? Lucy mentions, no second names. Lucy says, if my period is 23 to 24 days and normally the egg is released on day 8 or 9, will IVF help? How to make sure it will be a good egg? Well, there's kind of two parts to that question. So let's deal with the first part about cycle length. Because of the medications we use, your own pre-existing cycle to a large degree doesn't really influence how things will progress, because the combination of medications we're using are going to kind of take that process over. And I think that, that is one of the key advantages of IVF over all of the other fertility protocols we use, because most of the other non-IVF approaches still dovetail into your own natural cycle. How can we make sure it's a good egg? Well, whether we get a good egg or not, again, hinges on two things. Your baseline age. So age is the most important predictor of how likely we are to get good eggs, and also how many eggs we ultimately get. So the idea behind IVF is, I often use the analogy of a jar of jelly beans to represent your egg reserves. When you're born, you get a certain size jar of jelly beans. And when you ask most people, do they like black jelly beans? They usually say, no, not really. There's about 10% of the population that do. But if we were sharing out the jelly beans, which represent your eggs, over multiple rounds of sharing, what ends up happening is there's fewer jelly beans in the jar, and you end up with lots of the black ones left behind. Well, egg reserves are kind of the same thing. You've got fewer eggs over time, and the ones that are left aren't as good as they used to be. So if we're relying on nature, putting our hand in the jar and plucking just one out, there's a pretty high chance we'll get that black jelly bean. But if there is IVF where we're putting our hand in the jar and getting a bunch, we're going to improve our chances of getting some good jelly beans as well. So that's the key advantage there.
That's a great analogy, Andrew. I'm going to use that. Thank you.
I'll send you some slides.
Hey, the next question is, once an embryo transfer has been completed, is this counted as one cycle in terms of public funding? So the definition of a cycle for public funding is replacing all the embryos that you have created in that cycle. So we generally put back one at a time. We'd put back one in a fresh cycle, and then say if you had some frozen, you would then replace those embryos. And if you still hadn't had a baby, you would be eligible for a second IVF with the replacement of all of those embryos. The only caveat around that is if you're spectacularly good at this and you get a baby on your first embryo transfer, and then you have some frozen, and then you get a baby on your first frozen transfer as well, so you then have two babies, then from there on you're on your own in terms of the cost of putting the rest of those embryos back are your own costs as opposed to the government.
And I suppose that's just about being fair, dishing out that limited pool of funds towards people with no children first. Catherine asks, if the first transfer doesn't work, can you do a frozen transfer the very next cycle? Well, if you've got a frozen embryo, absolutely. And I really, I think that's, keeping that momentum up is really critical. Obviously respecting, at times you need a bit of mental space to cope with the, disappointment. But I think that's a really key thing in any fertility problem. Making that first step, coming to see us, and then getting a plan and keeping up the momentum. Don't sort of slacken off. We've got to just keep things going, be tenacious till we get to the bottom, get to where we need to.
Hey, Irene, with your really sad history, yes, you can stay on your progesterone for longer. So we traditionally wean at 10 weeks. Other clinics around the world wean at 12. But certainly there is no harm in carrying on with progesterone, and it's being used as a treatment for preterm labour. So basically, if you want to carry on, it's absolutely fine. Sorry, Andrew, I think I nabbed your question. I apologise.
No,
It's
no,
all
that's
yours.
okay. No, that's fine. Yeah, no. So that was about whether to stay on progesterone throughout the pregnancy, and absolutely. There's often some sad stories. So we've just got a question from someone who suffered their second partial molar pregnancy and have been told they shouldn't continue to try for a baby. Oh, question's moved. Shouldn't try for a baby naturally. We've experienced 4 miscarriages. What are our options? Well, I'm not sure who's told you that you shouldn't try for another baby naturally, but I don't agree with them. I think the thing about it might be that maybe you've been told to hold off trying for a period of time, because sometimes with these things called molar pregnancies, you need to have a break from pregnancy, because sometimes molar pregnancies can behave in a weird kind of way, and some of the tissue can then spread to other parts of the body. So I suspect that might be more behind what advice you've been given. But the fact that you've experienced 4 miscarriages, that's really relevant. And a bit like the question we had before about the low sperm count, you definitely need to see a fertility specialist, because 4 miscarriages is absolutely in the definition of recurrent miscarriage. And my colleague Simon McDowell, I think, he's going to be giving a talk on that sometime in the next week or so. So I won't give you a whole session on that. But there are tons of things that we can look for to see why that might be happening. And there are certainly options around treatment that we can try and help someone in that situation.
Absolutely. Hey guys, I really want to reassure you about wait times for IVF being the same as pre-level 4. Yes, we have lost a month, but we're still going to be delivering the same number of public cycles over the year. So we'll be playing catch up. So you're not going to be pushed out 100%.
Yep. Absolutely. Working really hard in all our clinics to get all those cycles back on track.
Yeah.
A great question here from Charlotte. How long is an IVF cycle where you need to do some genetic testing once you've retrieved the eggs? So with the slides I showed before, when you've got the blastocyst, there are certain situations where we can take a little biopsy from the embryo and then have it tested either for chromosomal abnormalities, so things like Down syndrome and other issues, or if you're a couple that know one or other of you perhaps carries a specific gene that you don't want to pass on. The usual turnaround time for getting that biopsy and then getting a result back is about 4 to 6 weeks. And so what we do is freeze all those embryos while we sit tight and wait for those results. Everything calms down, a bit like the overstimulated patients we were talking about before. And then once we have those results back, we will then contact you. I usually phone my patients for this, unless they've asked me to email them. And then we talk through what your options are in terms of having a transfer. So as soon as we get the results, if there's a good embryo to go back, we're keen to get the ball rolling.
Next, very relevant question about side effects with the medications we use. Look, most women feel fine. They work throughout the cycle, and it really is pretty minimal disruption to your life, apart from the day you have your eggs collected, where because we give you these fantastic mind-altering drugs, you're actually not allowed to make any legally binding decisions. But some people really start to feel their ovaries, particularly I think if you're a little skinny woman and you get quite big ovaries. And so you might feel a little bit bloated and a little bit uncomfortable and not feel like going for a run. Some women tell us they feel tired. Some women tell us they get some headaches. But I think that the stimulation we use is really much kinder than the way we used to do IVF. And for most women, they say, this was an okay process. I do think it's common to have sore ovaries for a few days following the egg collection. And it's like that feeling you have with a really heavy period where you've just got a sore lower abdomen, but it's certainly nothing that regular Panadol won't get on top of. And most people are really back firing on all cylinders within 2 or 3 days of their egg collection.
Next question is about where time-lapse is actually available. So one of the things about time-lapse as a option is it does require a specialised incubator. And so at the moment, Mary, you can correct me if I'm wrong, but it is available in Auckland, Wellington, Christchurch, Dunedin, but I can't, Hamilton?
Yeah.
I think, yes. So basically all of the FA clinics certainly have it. Mary and I don't work for the other clinics, so I can't speak for them, but certainly all our main centres that offer IVF do have time-lapse.
What's the current wait time for public funding? Look, it depends a little bit where you live, but it really falls in 12 to 18 months. So what generally happens is you're enrolled for public funding, and usually within around a month, you will know when your treatment will be. Yeah.
Katie asks about generally how long would a couple, in her case with existing endometriosis, experiencing infertility, how long would they wait before perhaps we would recommend IVF? Well, there's no one-size-fits-all approach, and that's where we look at the whole picture. So, for example, if you were in your mid to late 30s and you had reasonably severe endometriosis, well, we would consider IVF really early on. Whereas if you were in your early 30s or late 20s and your partner's sperm was really okay, we would perhaps go down the pathway of doing a laparoscopy, treating your endometriosis. Surgery alone sometimes is all that's required. Perhaps then try something called IUI, which is putting the fast sperm into the womb when you're ovulating. But if that wasn't successful after no more than 3 or maybe 4 cycles maximum, then we would move to IVF. So it's really an individualized decision that we will help you make based on your unique combination of factors. But at the end of the day, we'll always present you with the options that are going to give you the highest probability of a baby.
But as we spoke to earlier, if you've got endometriosis, you need someone with super swimmers to ever do it naturally.
Yes, yeah.
having a scan on Friday, who'll write down my follicle size if my partner's not there? Well, it depends which clinic you're having your scan in. Certainly when I did all the scans in Auckland yesterday, I had an assistant with me. If I who was writing down all the numbers, and but there's also occasionally if I'm, say, doing a peripheral clinic and I'm just by myself with a woman doing a follicle scan and I can't remember all the numbers in my head, then I will just ask the woman to write the numbers down as I go. So it
Yeah.
becomes quite a team effort.
Yeah, I'm like you, Mary. If the partner's there, I will get him to do it. In the current environment, that's not possible. I normally get the woman herself to write it down, but
Yeah.
I must say, because we're now in this, super fastidious thing about not wanting to touch extra things, I've had one of our nurses come in and enter the data. So wherever you're going to be, I'm sure there'll be someone who can, do that job for you.
Absolutely.
Now, thank you so much for your time. One.
You get the hard
Oh, I'm just reading through it. Is it common for you to freeze some eggs and make some embryos in the same cycle, or is it very dependent on the number of eggs produced? And secondly, I've seen that graph of AMH as a predictor of ovarian reserve. How reliable is this AMH test? A couple of great questions. So the first one, do we freeze eggs and embryos in the same cycle? The answer is usually not. Most of the time, if we are at the stage where we're wanting to make embryos, we want to make as many as we can. So every egg is a potential opportunity for that. Regarding AMH, it by and large is our single best tool for giving you an idea of what your egg reserves are. Like when you get in the car, you would feel uncomfortable not putting your seatbelt on, or back in the day when I played rugby, I wouldn't play rugby without a mouth guard. I would feel very uncomfortable recommending IVF without knowing what a woman's AMH is. It is a very, very useful test. And that even goes for those women that we used to say AMH wasn't so useful for, like polycystic ovary syndrome. I still like to know their AMH.
Absolutely.
Really helpful test.
So Zoe's asked, are there any situations where you'd put in more than one egg? And I think Zoe means to ask about embryos. And it's incredibly uncommon nowadays, and that's really because we're very aware of the risks around twin pregnancies, and what we want everyone to have is a great outcome, and also because freezing has got so good that therefore there kind of seems, what is the possible argument for putting two back when we know that our frozen embryos work equally well as our fresh? And in fact, last year our frozens actually beat our fresh slightly. So I think there's just very rarely an argument for putting two back, and certainly in our public cycles, absolutely not allowed to.
Absolutely. And I think if you've been doing this long enough, as Mary and I have, we've both had experience from our earlier careers where we have relented, put two back, and then there's been major problems with the pregnancy. And, I'll never forget a couple where I agreed to put two back. This is a long time ago now, and she ended up losing those babies at 19 weeks. And to this day, I wish I'd been a little more, rigorous about saying, no, you should have just put one back, because she might have had those babies. I'm sure it was just the fact that there was two there instead of one. So you never forget those stories.
Never.
If you Nikki asked, if you qualify for public funding but you don't want to wait and then do private treatment, is your place in the public waitlist held in case you're unsuccessful? Yeah, absolutely. You don't lose your place in the queue. What you want to do with your own time and money is nothing to do with the government. So if you want to proceed with treatment and you are able to, that's absolutely up to you. The only caveat is if it's successful and you go on to become pregnant, well, that's fantastic too. But clearly you would that you come off the wait list once we know it's a well and truly established ongoing pregnancy. Even then, if you go on to have the baby, you may still have enough points for future publicly funded treatment, because if you have had just one child, you will reaccumulate points over time, depending on how severe your initial problem was. I would say about 20% of our patients who are eligible for public funding choose to do a private cycle if they can.
Yeah. Lucy asks, if the eggs are released earlier than expected in a first cycle, which means that no egg is achieved successfully, who's normally responsible for this, and do they have to pay for a second cycle to achieve an egg? The answer is that this happens really rarely, and it's generally nobody's fault that you might have not reacted in the same way as 99.9% of the population does, and sometimes there's just no way to know that. And if it's a publicly funded cycle, then that doesn't count as a cycle. But if it's a privately funded cycle where everything has been done perfectly according to, all of our standard operating procedures, then it's just no one's fault. But sadly, you would need to pay for a second cycle. Although I quite often go to my CEO and say, "Hey, look, we've just had this really bad thing happen. Can we just do something really kind for this couple, because everyone feels bad."
Yeah, absolutely. That's not an outcome we would wish on anyone ever. Simone asks, how many embryos could you expect to end up with around 20 eggs retrieved? Well, Simone, that really hinges on a few things. I mean, starting with 20 eggs, that's pretty amazing. But, 50% of the DNA is coming from the sperm. So the conversion rate from so many eggs to so many fertilizing to ultimately how many embryos, a lot will hinge on the egg quality and the sperm quality. So the number of eggs retrieved is only part of the story. Also, things like your age would come into it as well. So a bit hard to give you a number there, but I would certainly expect that you would have something to go back. Yeah.
How long would we be waiting privately? Absolutely no time at all. We are open and ready.
Yep.
Yeah, yep. I like that question.
Erin asks, what effects do fibroids have on IVF? So just for the other viewers who don't know what fibroids are, these are actually a really common problem, or I wouldn't even say a problem for some women, but there's an issue where inside the uterus there are basically muscle fibers, and sometimes these can then develop into a growth called a fibroid. It's kind of like a hard, often roundish sort of structure, and about 40% of women will develop fibroids at some point in their lives. Fibroids only have an impact on fertility for two reasons. Either they are protruding into the cavity of the uterus, kind of like a boulder protruding through the nice soft soil in the garden, or if they're particularly large and creating distortion to the other structures. So when you see a fertility specialist, he or she will take great care to establish where your fibroids are, what the size they are. They may need to perform additional tests to figure that out. Sometimes we use MRI, sometimes we use something called hysteroscopy, and often surgery is recommended, but not always. So it's a case of looking at the whole picture.
So Amy asks, how many transfers does a woman usually have before they fall pregnant? And the answer is the best correlate of that is how old the woman is. And we can give you some pretty accurate stats around that. So for instance, if a woman is 30, she's going to have a 50% chance that she will become pregnant with her first embryo, and then a further 50% chance she's going to become pregnant with her second embryo. So it's very much age dependent. We've got a lovely thing on our website called the biological clock, where you can just dial it up and figure what your statistics look like. And the answer is, for someone who hasn't been pregnant before, is it common to become pregnant on their first transfer? And the answer is often. And so, so if you're young, you are going to fall into that 50% category.
Christy asked, does age play a factor in how long you might be waiting on the public waiting list? Age doesn't determine your priority. It's basically a queue. So you have to meet a certain threshold of severity based on how long you've been trying, what problems you might have, whether you have a child already or not. But once you are on the wait list, it doesn't matter what your age is. It's the same waiting time at this point. There was some work being done a year or two back to try and see whether women who are a bit older should receive a higher priority, but that's still sitting with the Ministry of Health at the moment, and unfortunately they're a bit preoccupied at the moment. Unfortunately, I can sort of see where you're coming from there, Christy. I suspect the question underneath your question is, if I'm older, will I get a higher priority? The answer is unfortunately no, and unfortunately once you're 40 and older, there is no public funding at all.
Poor Irene, who's lost a late baby, asking us, have we looked after some people who've lost babies due to preterm rupture of membranes? And the answer is yes, we all have, because sadly it happens. It's often linked with infection, and usually seen a maternal fetal specialist are the area of obstetrics and gynecology that are really the absolute experts in that area, and usually there are much better outcomes in a subsequent pregnancy. So I wish you all the best of luck for getting on this horse again, because it's tough.
Yeah, absolutely. I agree. Florence, Eden is asking. Sorry, another question. It's okay. You're allowed to ask more than one. So is genetic testing not routinely done at the blastocyst stage? No, it is routinely done at the blastocyst stage, but it's not routinely done in every cycle. So it is something that the common reasons people would choose to have genetic screening done is because perhaps they are getting a bit older. Most of the studies show that it's women 38 and older who benefit the most from pre-implantation genetic screening. But we certainly have had younger patients who have perhaps experienced recurrent miscarriage who really have lost faith in nature to choose the best embryo for them. So that's where we can come in and help nature along by choosing the best embryo, at least ruling out the ones that have chromosomal abnormalities. So
also for the people who just treatment hasn't worked, and everyone is keen to know why and get more information about your embryos. So often that's something we might suggest if it hasn't worked. Someone's asked, if you've had 4 failed IUI with severe endo, would I qualify for government funding? Certainly sounds like you should. There's a number of other criteria that go with it around BMI and smoking and children at home. So there's a bit to this scoring system, but from the information you've given us, I would hope so.
Well, it looks like Nicola's calling time there on the questions. We'll certainly endeavour to answer the other questions that that have been posted, and I'm always amazed. This is sort of a new stuff for us, isn't it, Mary? Where we've been quite active on the internet the last few weeks with COVID, and it's really encouraging to see.
Yeah, it's great.
All the interest. Yeah, I really enjoyed it.
It is. So thanks for the opportunity, Nicola. We've really enjoyed tonight.
Thanks, Nicola.
Thank you so much for joining us. It was a really informative session with lots of questions, and there's lots of thank you messages coming through on my screen as well. So thank you everybody for joining us, and thank you very much to Dr. Mary Birdsall and Dr. Andrew Murray from Fertility Associates. Next Wednesday, we will be having a session about the top things that you can do yourself to improve your lifestyle and fertility, whether you're conceiving naturally or via treatment. So we hope to see you next week. And thank you very much to our wonderful presenters tonight. And stay safe, everybody, and have a good evening.
Yeah, good night, everyone.
Thank you so much.
Bye.
Bring on level 2. See ya.